public anger is intensifying over Ghana's emergency response system following the death of Charles Amissah, a life many insist could have been saved. Reports that he was turned away due to the excuse of no bed have triggered outrage and renewed scrutiny of hospital capacity and emergency preparedness. The matter spilled into Parliament, where MPs across party lines acknowledged deep systemic weaknesses and called for urgent reforms. And some lawmakers admitted that the healthcare system is failing citizens in critical moments. Bayaga has this report.
Members of Parliament from both the majority and minority sizes in Parliament have expressed concerns following the demise of the 29-year-old man. According to them, a Ghanaian is not supposed to go through such a distressing situation. Delivering his statement on the floor of Parliament, Minority Leader Alexander Afenyo-Markin says that there must be a parliamentary inquiry to establish the reasons behind this particular situation.
We are informed that the Ministry and HEFRA have launched investigations. We welcome these actions, but let no one mistake executive inquiry for parliamentary oversight. Under Article 103 of the 1992 Constitution, this House has the primary duty to investigate matters of public importance and to expose inefficiencies and maladministration.
For Majority Leader Mahama Ayerga, he supports the position of the Minority Leader, but says that the investigation must be done comprehensively so that persons behind this are made to face the full rigors of the law.
This is what those who have done it today will be inspired by. They will talk, they will do nothing. We want to see action this time. We want to see people held accountable, so that the rest of the health personnel across the country will know that this Parliament will not sit idly by whilst people negligently lead to the loss of life, such as what we have seen.
Other members of Parliament also expressed concerns following this particular situation.
This is a matter of a tragic death, a matter that has now been announced as a subject of an investigation. There should be no basis for which at this time there are attempts to suggest that it is because the immediate past administration did not finish Agenda 111 buildings.
Mr. Speaker, but the most disappointing part is that no bed could simply mean that the staff are not willing to work. And that is the very, very sad part.
Responding to the concerns raised by the members of Parliament, Deputy Minister of Health, Grace Ayensu-Dankwa, says that the government will take steps to ensure that ambulances are retooled in order to enhance emergency response.
Mr. Speaker, in this government, we will take a bold step. The John Dramani Mahama government is going to take a bold step to solve the problem of no bed syndrome. Mr. Speaker, we are going to retool the hospitals.
For the Speaker of Parliament, Alban Bagwin, this particular situation must come to an end. And with this, it says that there must be a legislation in order to address it.
This is one of the needless deaths we have experienced in this country. At the end of the day, I will urge the House for us to legislate on the matter. We need to pass an emergency care law. Emergency care law on this matter.
Reporting for Joy News from Parliament, I'm Fatau Bayaga.
Our consultant emergency physician Dr. Godfred Tichi joins us with more on this. He's written an article offering solutions to the problem. We're grateful for your time, Doc. When hospitals say no bed, is that sometimes just an excuse?
Okay, thank you for having me, and good morning to your viewers and to you. It's not an excuse. When they say no bed, it's actually a system failure. It's not really about beds, but that's the colloquial terminology that has come to stay. That's my initial response. Thank you.
Right. You say this is not a bed shortage, but a coordination failure. So who exactly is failing? Is it the hospital management, the ministry, or the doctors?
Okay, so from where I sit, I don't like finger pointing and blaming. We have not created a system over the years that is properly coordinated, because it starts from a few areas. You see, in the past, a lot of people didn't know of us. We are emergency physicians. We are a specialty on its own. And I can say that up to date, some people still don't even know we exist. So there's a chain of emergency care on what we call the emergency system. So you need what all emergency starts from the community, at home, school, church, events, or any social gathering, okay? So you need some form of training in the community. You need some form of coordination between that training and the pre-hospital care. That is what we call the ambulance service. Then you also need a coordination between the ambulance service and the emergency departments. And it doesn't end there. You need to have a national emergency care system. So it's unfortunate that it appears that there's always a bad outcome before the media picks this up and we start this conversation. I know from where I sit that a lot is going on behind the scenes, but I would say I will not blame a system on government or hospital or an agency. It's something we've not done to a level, which I think we have an opportunity to do now. Thank you.
I'm confused about is we know this is supposed to be done, but we've not done it. What seems to be the problem? If a patient goes to the hospital, should that patient be turned away, under any circumstance?
As I've said, under no circumstance should any patient be turned away. If you follow the solutions I professed in my article, we need to have what I call, or what I term, national triage utilization standards. Means that every patient who arrives at the facility must be assessed immediately, stabilized. And then if there's a need for that patient to exit that facility to another facility based on lack of capacity at the initial point of call, then that referral is done. But the referral is not just scribbling something on a piece of paper and say, relative A, take it to hospital Y. There has to be a proper coordination, which I said over the years, we've not been doing. And it's unfortunate that things have to happen this way before we come back to this conversation. Let me draw your attention to something. Over the past 10 years, there have been many incidents of no bed syndrome, but our approach has not been collaborative enough. We've not tightened our coordination. And let me also say this, that the specialists who take care of emergencies, until 2012, there was no emergency doctors in Ghana. So we've made progress, okay? We've made progress. There's a lot ongoing. I know the public will be frustrated and all that, but there's a lot ongoing and we hope to nip this in the bud. This problem is solvable, okay? I don't know if I have the time to go through all my solutions. Do I have the time, please?
Give us, we'll let you know when we have to go off that.
Okay, so the first one is the National Triage and Stabilization System, okay, which I've just talked about. That will address patients being turned away. So there should be a clear guidelines that nobody should be turned away, which I know Ghana Health Service put this out so many years ago. So the second solution is real-time bed visibility, okay? So we need to use modern technology, okay? So we need to have a way of telling that this hospital has space, this hospital does not have space, okay? And all these are connected to what we call escalation policies in various emergency departments. These are all things we have worked on that we are yet to implement in various emergency departments, okay? So we need a very simple, scalable bed visibility system that works both digitally and also in low resource settings. If you take areas where they don't have good internet, we can use manual reporting of certain metrics that we call QA, quality assurance. How many of your beds are occupied? How long does it take for you to get patients off the ambulance? How many patients are staying longer even though they've been asked to leave the emergency ward to go to the other admitting wards like surgery, medicine, OBGY, pediatrics, and the rest, okay? All this must be done and coordinated nationally. So regionally first, then nationally. The second solution is what I call flow problem, okay? Flow means that, or a lack of flow means that a patient who needs to move out of the ED is still in the ED. That's what we call flow problems. We lead to what we call boarded. If you are boarded, it means you are not moving out of the ED. And that is where the problems comes in. And that's the bottleneck. When patients stay longer in the emergency department, that is the entry point. So the hospital may have beds in other wards, but the entry point is choked. It's like the funnel analogy. You know the funnel has a wide entry point and a narrow neck. So when you have so many patients being boarded who cannot leave the ED or the emergency department to the wards, then the emergency department is perpetually choked. And another thing I need to talk about here before I move to the ambulance coordination is that we need to strengthen our smaller facilities. Certain conditions can be managed in smaller facilities. Here, if I take example, Kolebu, I've worked in Kolebu before. I've worked in, I've been to police hospital, I've been to Rage, and as an emergency physician, and we communicate with each other. Their problems are that there are a lot of conditions that can be managed in smaller hospitals. They all get up being sent or dumped on Kolebu or 37 or Rage or what have you. So what happens is that there's so many patients there. So when real emergencies are coming into the facility, there isn't physical bed to admit the patient. And even when there's a physical bed, the physical bed may not be ideal for that scenario that the patient presents, okay? So let me move to the next one. The next one is what we call ambulance coordination system, okay, with the facilities. If the ambulance have access to the real-time bed visibility, they will know clearly that I don't need to send this patient here. So we need to have a properly coordinated ambulance to hospital coordination, which we can use technology, okay? And all these are things we must do. Then the last one I want to talk about, last but one I want to talk about is what we call monitoring data and accountability, okay? So we need to find a way of reporting some of these events, not just when things like this come in the limelight. We need to know how many cases at the EDs are being refused by a particular hospital. We need to report this. We need to report it and deal with it. We need to reduce how long patients stay in the emergency department. We need to reduce all that. We need to have national standards that we can't allow patients to stay in the emergency department beyond a particular period, for which you need to trigger the escalation policy, okay? We need to know how many of our beds are actually functional. They're talking about functional bed space. How many of our beds are functional? How many people, when we turn away from a particular facility A to facility B, actually die in transit? So all these are things we need to collect. It's data. We need to collect and analyze and see where the loopholes are and how we can improve, okay? Then the last bit is what I call low-cost Ghana-ready nature, okay? We don't need necessarily to build new structures or put more beds necessarily in the emergency department. What we need is a proper coordination and flow system, okay? And we need that bed visibility system in place. So it's basically redesigning of the system, redesign of the emergency care ecosystem. As I said, emergency flows in this way: community, then pre-hospital, emergency department, and to other areas like ICU, to the operating theater and all that. So if a particular chain is broken along the way, it will affect the way we function as an emergency care system. And for me, we can end no bed syndrome because it's achievable. And I don't want to blame anybody. I don't want to point any fingers. We need to build a modern emergency care system worthy of the Ghanaians that we want to serve. Okay, Ghana has a good number of talents. We have the expertise and the will. What we need now is proper coordination using modern approaches that saves lives so that we can restore public confidence in the work we do. So I'll pause here. If you have any questions for me, I'll try and answer. Thank you.
To know from you is Parliament Speaker specifically said that laws must be passed to at least sanction any refusal at the emergency care unit. Do you agree?
Yes, we need to have laws, okay? We need to have laws. Let me propose this, okay? And these are non-negotiable. We need to have a National Emergency Care Act. Okay, elsewhere, if you go to the US and other Western parts of the world, they have laws that govern how emergency care should be practiced. So we need to have a National Emergency Care Act. We also need to have what I call National Emergency Care Directorates. You know, when you go to Ghana Health Service, they have so many directorates. If you go to Ministry of Health, they may have similar things, but we don't have a National Emergency Care Directorate. So I'm advocating, myself and my colleagues, we are advocating not just the act, but the act needs to have legs to stand on to function and operate. Right. So we need also a National Emergency Care Directorate. We also need national triage standard We need national referral and transfer network. We need national bed visibility system. We need national ambulance ED integration. We need national emergency department staffing norms. How many the doctors, nurses, the different mix of healthcare cadres are supposed to staff a functioning emergency department. We also need what we call National Emergency Care Training Pathway. We also need what we call National Emergency Car Dashboard, so that when at the ministry, they put on the screen, they can tell at a glance, Greater Accra, these are where the issues are supposed to be coming from. This is a potential bottleneck we need to resolve before it becomes a disaster. So this, you should see it, once you put on the computer, it should display. And herein, we should use the IT guys we have in the country, okay? We also need to have the last, not the least, we also need to have what I call the National Disaster and Surge Frameworks. We always tend to be reactive. We should rather be more proactive and take steps to nip things before they become a national disaster. This will be the backbone of a modern emergency care system for Ghana. Thank you very much.
Thank you so much, Dr. Godfrey Techi, and he's a consultant emergency physician joining us on this issue. Well, we're grateful that the Health Ministry's spokesperson, Tony Goodman, has also joined us via Zoom, and we understand that the ministry has set up a committee to look into the incident. So, Tony, what timelines is the committee working with?
Thank you very much, and good morning to our viewers and listeners. The committee is expected to submit their report on the 10th of March. This committee is chaired by Professor Abedu Akosa. And the members, some members I can recall is Dr. Koku Williams. We have other public health experts, an emergency physician, and a lawyer on that committee. They have started working yesterday. They invited some critical and emergency nurses and other nurses to also assist in doing this work. Their work is not only going to look at this, even though we want to look at reward and sanction as part of their work, this will also strengthen our emergency care in Ghana.
And Tony, who takes responsibility when a hospital refuses a critically ill patient and if that patient dies?
Who takes responsibility?
Yes.
Let me say what we want to see as an institution or Ministry of Health. We don't want any patient to go to a hospital and be turned away. We have issued that directive in the past that if a patient is brought into a hospital under emergency, don't say no bed and then go. To even say that there is no bed, it should be somebody of high status or a responsible person, which means that somebody has responsibility to do that, not the security man there, not any other person, but a person who should say that must say it.
All right. And we know this problem of...
So even if you have to stabilize this person on the floor, please do that. You must first stabilize. Even if you have to stabilize in the ambulance, you must do that. If that is done, then you look out for where you can now move the person to. These are some of the directives we have issued. But we have noticed that it is not only bed issue. It has to do...
we seem to
have to do with people who are trained properly to take care of emergencies. As I speak to you, the Minister for Health is currently working with the Ghana College of Physicians and Surgeons to produce enough specialists to take care of emergencies. We have not produced enough specialists, trauma specialists, accident and emergency specialists, enough to take care of some of those accidents and emergencies. Currently, we are doing that so that we can spread or expand healthcare to these areas. Some of the places, they can rush through there. But
does this training include paramedics?
Yes, currently, we are looking at nurses, medical officers. We have already done for lab scientists. We've done for pharmacists. You know, we now have We have all those things. But now we have not done some of those things. We are lagging in that area. We don't have enough specialist nurses. We don't have enough specialist medical officers. So under the health training institution, we are rolling out this program this year. We will start the adverts this year to train oncology nurses, cardiology nurses, nephrology nurses, emergency care, critical care, and other specialized nursing program. These are some of the things we need to do to augment what we have. If you do that and you're able to decentralize, get them to go to other facilities to work, the person may not be rushed to reach Kolebu or UGMC. Wherever these specialists are, they will be taking care of these patients to reduce the burden that comes to the central point. These are some of the things we have begun, and we hope that when this one is ruled out and is successful, with the coming in of the free primary health care, which is also coming in April, we are going to talk about a lot of preventive and promotive issues. Under the free primary health care, we're going to station some kiosks, some personnel at various places to educate us, get us to know our disease burden and what we are supposed to do.
Well, Tony, let me come in here. I'd like to know, because one of the major issues that have come up is the lack of triage protocols. And when was the last time the ministry reviewed the national emergency triage protocol? Because really, when you go to our major hospitals, these do not exist.
You see, there are protocols, there are policies that are being implemented. As to when it was reviewed for the period I wasn't here, I won't be able to say. But if you look at this to do as part of the work of this committee, to look at these protocols, and if then we have to review them, they would recommend to the minister. But what is more important, what we have noticed, is that we need to train a lot of specialist medical officers to expand healthcare. If you send people, you centralize emergency and the people are rushed to Ridge Hospital, they are rushed to Kolebu, and you have just about 4 or 5 medical or specialists there, the place will be choked and you'll be told there is no bed. But if you train more and you decentralize, wherever these things happen, they'll be taken care of there. These are accidents, emergencies under the non-communicable diseases, diabetes, people with heart issues, cardiac arrest issues. We are saying that under the free primary health care, if they are given proper education, they are screened. You go through you check your weight and all that. If all of these things are done under the program, we will reduce disease burden under the non-communicable. Persons who have non-communicable disease already and are suffering to take care of themselves, the Mahama Care, the Ghana Medical Trust Fund, will take care of those people. So it is to take away the financial barrier also. It's not to just put in place the facilities and you and I may not be able to get the resources to go. There should be the break in that financial barrier. Remove the financial barrier and make sure that you have universal access to universal coverage. These are some of the things we want to do. Various strategies we have put in place quickly to help the people of this country.
Thank you very much. Tony Goodman is PRO of the Ministry of Health.